Great. Well, we have about a half an hour for questions and discussion. I want to thank both of our panelists so much for these very impressive and inspiring talks that they gave. I know I have a lot of questions. Maybe I'll kick one off while we wait for people to line up at the podium. I'm sure you have along the way, despite how you close, Judge. Both of you have experienced some pushback along the way. You know, what are some of the major concerns people raise about what you're trying to do in terms of reform and reinvestment, counter arguments, and how have you dealt with that? And I would assume one is when you're closing facilities, people are losing their jobs in communities. But you know, there are other things that you've constantly found you have to, you know, keep addressing in terms of concerns.
You want to go first?
Go ahead, Judge. The judge always speaks.
You're so kind, Elizabeth. Yes, there is some pushback. However, for me at the local level, there was, you know, when you start at the local level, you probably can run a greater risk of pushback, but I was able to, I believe, reduce it in the same that Governor Deal did, is by the way that we approached it. We approached it in a very collaborative way. So one of the things I didn't mention, but it's part of the 7 core strategies, that if I had the time to break them down into specifics, would be approaching it with an all-inclusive, body of stakeholders. Now, however, that doesn't mean, I don't want to suggest it's an unwieldy group, because we use what I call as a unified stakeholders approach. That is, there are those who are the voting members, and then there are those who are the advisors. But those advisors really wield a lot of influence, like the Prosecuting Attorneys Council of Georgia, or the Public Defenders Council of Georgia, or the local County Commissioners Association, okay? They're all there at the table. They're sitting there with us, okay? But it's using that approach by bringing everyone in. The other thing, too, is this, that was very helpful, is that there was 2 basic ground rules, okay? Number 1 is that it's not done by majority vote. It's done by consensus. The consensus approach allows for compromise, and that was mentioned earlier by someone, I think, sir, you know, and mentioned, compromise, that, look, there were some things I had to give up. There were some things I wanted. But I was so happy that I got something that was better than nothing. You said that, okay, in the last hour or so. So that was rule number 1, okay, all right? Now, and by example, I wanted the one that said that a judge can commit no misdemeanors whatsoever, period. Well, I had a prosecutor on there, a longtime prosecutor, you know, who said, I don't know if I'm going to go that far. I'm willing to go with the second one, which is you cannot commit on any misdemeanor unless there have been 3 prior acts of which that child's been adjudicated, and at least one of those has to be a felony. God, he went to the next one. Oh, I'm thinking in my head, I'm going for it. I'm taking it now. I'm not going to argue with them, okay? That's good stuff right there, all right? See, that's how consensus works. We get the work done, all right, quickly that way. Number 2, we do not make any recommendation to the governor unless it's supported by the data and the research that Elizabeth was talking about. Why is that important? Because you see, some of these changes require legislative action. We have to go before our legislative body. And in this particular case, being a Republican-controlled Senate and House, which, you know, their philosophy historically has been, you know, a little bit more punishment, okay, you know, to conform behavior. And so we wanted to be able to go before them and to point, not to anecdotal stuff. We don't believe in anecdotal stuff, okay? All right, unless that anecdotal story is one that is supported by the research. and can demonstrate that. But it's based on research and data only. And that's what won our Republican legislators over. The second thing was that how much money it was going to save as well. See, we were able to combine the two, all right? That, I mean, do you really want to explain to the taxpayers, not that we said it this way, okay, but do you want to explain to your taxpayers that you're actually wasting money, okay, that you're actually investing in things that don't work, but we are offering you things that do work, all right, and you can go home and tell them how you're saving money and improving community safety, all right? So that to answer your question, the one thing that we did have a challenge, but this is the way that we dealt with it, was that culture change. What I call the paradigm shift, helping people make that paradigm shift, because they're used to, they're going back and they know they have constituents that still kind of get on that tough on crime. However, though, when CSG and Pew, when they come in, you know what they do? They do surveys of the population, right?
Right.
They poll people in the state. And I will tell you, there is not a state that I know of, Elizabeth, okay, in which the people do not favor, let's say that they are more in favor, I'll put in the positive, that they favor more rehabilitation and using community-based programs than putting kids in prison. There's something that's just not sexy about putting kids in prison. You know what I'm saying?
On the adult side, a lot of people want to put adults in prison.
She has it tougher.
And I didn't talk about racial and disparity impacts in the adult system, but obviously that's an issue that we're addressing as well. I mean, a number of things. I absolutely agree with the judge that you not only need champions, you need a very deep bench of champions, especially when your champions are elected leaders because of term limits, and those folks come and go. I will say that you also experience different stakeholder groups that will have issues, prosecutors, law enforcement, and that's where your champions can be helpful. I will say that we have any number of resources that we go to when those issues come up. We do peer-to-peer talking. If we have a prosecutor who is really against something in a state, we get a champion prosecutor from a similar state to help talk with that person. We use the data, but I think everyone in this room would say and probably know that sometimes the data isn't enough. And sometimes people don't believe the numbers. Does that ever happen? No. So when someone doesn't believe the data, we rerun it. We show it to them differently. We have another focus group meeting to talk about the data. It is such an exhaustive process. The resources that go into this project to provide the technical assistance and the expert is really something that in some ways is a luxury to be able to do this, to have those extra meetings, run that extra data. Like I can tell you, we have staff literally working 19 hours a day to provide the information to get policymakers and stakeholders to change their opinions on this. So it's not easy. It's a very difficult and hard lift. And I will also say that there are really unfortunate instances where somebody who is released on community supervision commits a really heinous crime. And so then how do you have a conversation? Because it's a very high profile incident and something really horrible has happened. So then how do you go back? But the evidence says, the research says, look at how good our numbers are. It doesn't matter. Somebody's been killed in that community, and you need to be able to respond to that and have a response to that. So it isn't all easy. It's definitely putting together the different pieces and having those conversations, knowing what's in your toolkit to go to. I will also say that there's a benefit to this project because you have the Koch brothers who want to support it. You have the ACLU who wants to support it. So when you're like, I don't know, who am I going to talk to this person? You're like, I don't know. There's a lot of different resources that we can lean on. And I think that's also, a benefit here because a lot of people are sort of game to do something about this. Whatever element brings them there, the human element, the research, the numbers, the cost savings, the rehabilitation, everyone's at the table for maybe a different reason, but they stay at the table because of this idea of consensus and working together.
If I may follow up on something in support of that she said regarding that incident that can happen with a person on, community supervision and does something horrific like kill somebody. So let me share this. The Second Chance program that I mentioned, which are deep in kids now, to be eligible for it, the state had to recommend that the kid go to prison, a youth prison, okay? Typically, the recommendation was 3 years, all right? We could send them up to 5 years. It's pretty tough in Georgia, okay, in that sense. We've changed that law a little bit, but I'm not going to go into that right now. But so we created this I created in 2010. It's a very intensive program based on best practices, but the first 6 months these kids are on GPS house confinement, okay? I mean, we know where they are. They go to school. Back before, they can't leave the house unless they're with their parent. Their parent's placed under an order as well and can be held in contempt, okay? It's tough, all right? But we pick them up every day at school. We bring them over to an evening reporting center. They go through Thinking for a Change, 7 challenges, life skills, you name it, all the things that are evidence-based. We've now graduated a little over 70 kids since 2010 with a 6% recidivist rate. So my follow-up in support of Elizabeth and how you have to kind of, handle and manage this, the approach is talking about the law of probabilities. If I know that if I'd sent those 70 kids to prison, 65% of them would have reoffended when they got out. Now, I'll be frank with you. One in that 6% did commit murder. Okay? But there's 2 things I want to say about it. Everyone on the team knows the law of probabilities in Clayton County, the district attorney, everyone. We talk about it. We know the risk, but we also know there's a greater risk if we send them to prison with a 65% recidivist rate, that one murder could have been 2 or 3. That's the law of probabilities. You see, you're not going to hear the phrase perfect practices. Not in this business. It's best practices. It's about reducing the risk. But when that risk happens, when it's realized, don't sensationalize it.
Sandy Magnum from Minnesota and co-chair of the roundtable. So thank you so much for being here. If we weren't inspired before, you certainly ratcheted it up for us. So thank you so much. So I have 2 questions. One is about how do you engage and the clients, the families, such that they don't feel disempowered by like a new system that's been put on them. So how are you engaging them and listening to them in that process? And then the second is, as we are the Roundtable on Population Health Improvement, you're doing some of our work. You're doing, how can we be helpful to you? How have you seen that health, public health, healthcare systems can help you even more than what you've seen? Or if we've been a deterrent, let us know that too. So.
I just feel the need to interject because I'm the timekeeper and I'm looking at the clock. We don't have a ton of time, so if we can have some, pretty short responses.
I'll say, come on. Paula?
Kind sir, and then maybe we can get to some more questions before we break for lunch, and we can have longer conversations over lunch.
I think I'm going to take your second question first, if I can. One of the things that I found particularly challenging when we rolled out, and going back to my West Virginia example, when we rolled out funding to increase substance abuse services, and I don't know if this is exactly within the conversation you're having, we could not find treatment providers who wanted to take the money because nobody wanted to work with criminals. They wanted to work with kids. Non-criminal kids, maybe. They wanted to work with folks who just had a mental health issue that needed to be addressed, or they had a drug issue that hadn't turned criminal. And we find that in a lot of the places where we go, that treatment providers get into the work that they do to not work with criminals. And we had to actually work very hard to think of how we could incentivize that and get people to come to the table to provide the services that were needed, because the people didn't want to provide those services. So thinking through that is something that has long been a challenge. Other pieces about how we can provide access to services. So many of the places where we work are very remote. We've been piloting telemedicine. We've been piloting other different types of approaches. But this idea of how, like, evidence and best practices show us that individuals do best when they're in their communities, but if those communities don't have services, how can we deliver services to help kind of wrap that around? There's another huge challenge that we've been piloting and thinking through and working on, like, how can we make that work? Another really big issue that we've done some work around is when adults leave the adult system, very often they have medications that they need to help address whatever underoccurring issues they might be dealing with, how we can get state systems to provide a prescription that lasts more than 30 days, how they can have access to a doctor to get those prescriptions filled. We piloted some projects in West Virginia to leverage their Medicaid expansion to, like, get access to those services, but some of those very specific pieces we hear in almost every state that we try to enact these reforms. You know, there are not enough doctors to fill these prescriptions. We know from evidence that when you're released on supervision within a community, that first, like, 60-day period is, like, your time when you're most likely to reoffend. So we have to make sure that that time is most closely coordinated in terms of care and services and programs that are provided, and those are some of the biggest challenges that we run into.
I'll take the first question. Sandy, that's an excellent question, and that's where the rubber hits the road, quite frankly, because many of these families really do not want your intervention because they just don't understand. They're living a culture that's their lifestyle that to them is normal, okay? Yet they don't realize the trauma they're going through, okay? So so this is really a skill and an art, which means that the providers that we recruit have to understand the responsivity principle of programming, and that is that we need to make sure that they have the staff that has the skill and, you know, that set of skills to be patient and to know how to positively manipulate that family, so that at the end of the day, it's that parent who thinks he or she is the one who had the idea to do this, okay? Now, however, if we have the time to really talk about the nuts and bolts, so I don't, but I will say this, you will run into those parents who themselves have mental health issues that even suffer from mental illness, and we're running into that are not treated, and they don't realize that, okay? And so we're having to deal with yet another level, because we're dealing with the kid, but we're really dealing with the family, and they're all interconnected. So we have all these ways of dealing with, even the belligerent parents. We have ways of dealing with the belligerent parents, okay? But it's a positive, just like we deal with kids in a positive way, we deal with the parents in a positive way. We never pull that trigger on a parent where we have to bring that parent into the juvenile court, okay, to put an order on that parent unless it's absolutely, absolutely necessary for the kid's welfare. And as far as the health department is concerned, Dr. Alpha Bryan, I know Chris knows Dr. Alpha Bryan. He's doing work with our Clayton County Health Department, okay? She is a wonderful human being and a tremendous professional, but she's the former executive director of our system of care. That's how involved the health department is.
Martha Gold, a member of the Roundtable, New York Academy of Medicine. You've both talked about the role of an evidence base in persuasion, and one of the things that we've been grappling with the Roundtable is how poorly funded the research is for the evidence base that we need. I wonder what quality of research you are using and how much pushback you get in questioning from the legislative folks you have to convince about the robustness of the evidence you're providing. And who funds that evidence?
Yeah.
We're actually doing some pretty cool things right now. We're trying to pitch to researchers to do even more work around this and kind of letting them know, because so much of this data has to be collected, there's a lot of really interesting information to dig and mine and report on, and we're like trying to sort of like tantalize researchers to come to the table. I will say there has been great federal resources behind some of researching these programs as well too, and I wanted to make a comment about evidence-based programs. It's a really nice term, and a lot of legislation now does mandate that you can only fund evidence-based programs, but I personally find myself sitting across the table from a corrections director, a governor, a legislator, appropriator, and they're like, but this program works. I'm like, actually, it doesn't. And that's a hard conversation to have because you have to be able to sort of show. But at the end of the day, you typically can turn the conversation to something that says, we really know on the adult side, there's very few programs that have really shown significant results in reducing recidivism. And those numbers are very clear. They've been tested. They've been piloted. We've seen them in states. And so when we can say to a legislature, you really only should be running 2 programs in your institution, not 10. And they can be like, oh, wait a minute, you mean I can reduce the wait list for my programs? I can have individuals be parole eligible sooner because they completed their programming. You know, for those of you who don't know, Dr. Ed Latessa from the University of Cincinnati, he's like this amazing personality, and he can only carry off these jokes. He'll be like, heard about a knitting program in prison. Do you get a rehabilitated individual? Nope, you get an individual with a sweater. So, you know, and then in having those conversations, like what actually changes behavior, and the fact that we've been able to track recidivism rates help us to tell that story. And then you have folks like Ed Latessa who can like present that, and just everyone's like, oh, all right, that kind of actually makes sense.
Funniest thing Ed told me was, about self-esteem programs. You know, what do you do when you put a inmate through a self-esteem program? Well, they get out and they just commit crimes more confidently. But I want to point out there is some tension or conflict right now about the reason. You're right about who asked. Where are you? Who asked that? Oh yes, you know. If you go, okay, let me first of all do this. On the juvenile justice side, if you go to www.communitysolutions.gov, they will, that's OJJDP, Office of Juvenile Justice Delinquency Prevention, they lay out for you all the programs that are evidence-based, that are promising, and that just don't work. And they do it very easy for the visual like me, green, yellow, and red, okay? Here's the problem, though. How long do the programs in the yellow have to be stuck there? That's really your question, okay? You see, how do we get the funding that's going to do the because the studies require longevity as well, okay? All right? And that's the problem. So we have those promising programs. And I think what we may need to do is this. And we've talked about this in Georgia, that we may need to relax the evidence base and open it up to promising programs for purposes of allowing for study, okay? Especially now that we have such a significant reduction in out-of-home placement, okay? See, we had this discussion up front, by the way, but the reason we decided to go with evidence-based is because we had to take drastic measures and we had to convince the legislature, and it just didn't sound good to try to get the legislature in the first year to hop on board with, well, we're going to use some promising programs. Promising, what does that mean? Now, I'm not going to put my money in a promising one. So there's the politics of that. That's just reality. Life's unfair, so we have to learn to move with the unfairness. But now that we've reduced that population, we've accomplished our basic mission. We're now beginning to revisit that. That's a good question.
I think we have time for one more quick
Okay,
question.
I'll be quick. Mary Pittman from the Public Health Institute. Great panel. My question was around the family and the community that surrounds these people. You started to talk a little bit about it, Judge. But I'm thinking about the family that has one disruptive, maybe chronically disruptive youth in the family. how do you begin to move into the other family members to prevent them from following that same path? Is there a cluster of programs,
Yes.
best practices that you've identified for that?
Well, Elizabeth and I would talk, I'm assuming, not to put words in her mouth, and if she disagrees, just, object. Like a lawyer would object, right? Okay? And I promise I will not overrule you. And it's this, MST and FFT, okay? For example, since you mentioned in your question programs, okay? So multi-systemic therapy and functional family therapy. Now, I will tell you this. In our first year, the first 2 years we used FFT, functional family therapy. This year, we switched over to MST, multi-systemic therapy. Now, this is where you have 2 or more clinicians, but they go into the family, they actually go into the home. And what they do is they do mapping of the family, and they develop a treatment plan for the entire family, for everyone who lives under that roof, okay, identifying all the issues and things of that nature. And they have to be certified in this. This is not just something where you're a therapist and you can go do it. You have to be certified in MST and FFT. Now, we moved because we realized, because we're collecting data locally, okay, we're measuring that data. We have an outcome and performance measure instrument that we use. And we found that most of our families in which their kids were at risk of being committed to the state and had that disruptive kid, that they needed a more hands-on approach, which MST tends to deliver over FFT, okay? In other words, they're the ones who get down. The first thing they do is they do the Maslow's hierarchy of needs, the basic stuff, transportation issues, food, shelter, all that stuff, okay? All those impediments, because it's really kind of hard to get you to think about changing the way you see the world around you when you're hungry or you can't get to work and stuff like that. And so, you know what else we're getting from so far from our court officers is the responses from the families, and that I guess I just have to say they're happier, because they're actually seeing tangible things right from the very beginning. Problems that they're facing being solved. But it's not that the MST person is solving it, okay? The MST person teaches them how to solve it. Helps them understand that, the solution is in the problem. Let's look at the problem. And walks them through it, okay? And then it empowers the family. But everyone has to be involved in that, okay? So, yeah, you may go in and little brother or little sister may have issues. They're going to deal with those issues as well. Not just on Joe, who's the one who came before me.
Are they starting to also move to the surrounding community? I guess from a population health, that would be where we would expect kind of your next step to go?
Yes, well, that's why we do the system of care, so that's part of that expanding. So let me tell you, right now we're only in the middle schools, okay? We're in all the middle schools. In fact, so far this year, the system of care, the schools just started, has already serviced 300 kids. They have 300 kids right now. I've dedicated 2 full-time staff to the system of care for in-kind, all right? Where we want to go is not the high school, okay? Because believe it or not, the delinquent acts go down in high school because you're beginning to age out, all right? You know where we want to go? Our next step is to go to elementary school. That's where we want to go next. We have a plan for that. And eventually we want to go into our hospital, into the birthing rooms.
I just want to quickly add different programs on the adult side than the juvenile side, but I think we've talked a lot about, stakeholder engagement, elected leaders. I don't want to get lost that a really important part of this process that we spend quite a bit of time doing is going and talking to individuals who have been formerly incarcerated, talking to individuals who are on community supervision, talking to their families, leading those focus groups, because you can get the data, you can get the evidence, you can do the research, but you have to go and talk to people that say, what works for you? What needs to be done? And that's part of sort of and a lot of times elected leaders don't want to hear that. So then we provide forums for them to provide testimony, or we channel it through. so much of our job is what we call shuttle diplomacy, carrying this message from here and putting it over here and making sure that they're connected. That's a lot of the work that we do. So I just want to say that even on the adult side, I think it's really important that you treat people like people and you talk to them about what they need and what works, and not just do the numbers and the research and get the governor and the speaker. You need to talk to people too.
And Paula, can I just, one quick thing? I just want to say one thing. This conversation we're having is not a new conversation in terms of best practices, how to do things. I have a letter here in my father's handwriting, March 29th, 1968. He was a U.S. public health advisor at the time. He retired at CDC, so he knows epidemiology. He is my mentor.
And so do you.
Yes, from him. This letter, he was in Atlanta at the time, by the way, okay, and he's writing back to my mom, a day he wrote every day, but on this one, he's excited about a comprehensive health plan that he's working on. I don't have the time to go into detail, but he details it here. It's really what we're talking about here, okay? But do you know what the problem was? There was not the political will, there was not the infrastructure, there was not the practical stuff that he wished that they would have done. And he talked about that, and it failed, okay? It failed. But the concept is not new. He was right from the beginning.
It's great, and you've invoked your father. I need to invoke my son, actually, who is a clinical psychologist and works in multi-systemic therapy, and actually just published a big article on the cost-benefit analysis of MST and how it saves a ton of money. And so if anyone wants to know more about the research base for MST, Proud Mother would be happy to talk about.
Way to go.
Thank you so much to our panelists. Again, so inspiring.
Thank you, Paula. Thank you, panelists. We've had some invocations of father to son, and I'm going to invoke lunch. It's lunchtime. I'm thinking what we could do is model the capture and reinvestment that we're talking about. So I'm going to capture some of our lunchtime to reinvest it a little bit later on in the afternoon. So we were originally scheduled for an hour for lunch. We're just about 10 minutes into that. I am going to ask that we resume exactly at 12:45. The sign of a really good meeting and conversation is one that ends not just on time, but ahead of time. And so I'm going to be pushing for that. So the directions for lunch, Lena, I'm assuming you head out through the door, and voila. So 12:45. Promptly, we will resume. Thank you so much. I know you've been drinking from a fire hose.